Okay, let's try this again. Yeah, I set up the WebEx meeting through my office computer, and I guess the only thing I could see was my mic was left on mute. So anyway, unless someone can read lips, the first video won't be very helpful to you. Okay, donor selection and phlebotomy. Also with this PowerPoint, I went ahead and typed in notes in the notes section. So if you want to print the PowerPoint also with the notes, just as extra things that I may have entered into that or that wasn't necessarily on the PowerPoint slide. So the donor selection and phlebotomy, this information will not be on, any exam or, definitely not your final exam. Because you may need this information for the BOC, but it's just, if you actually experience the donor donation process, it'll probably be a little bit more easy, and then you'll kind of understand the the guidelines for that. So I'll go ahead and get started. So the FDA establishes donor criteria through the Code of Federal Regulations. So guidelines are written for the donor. You have a donor and history questionnaire, and the questionnaire must meet, the FDA's requirements. So when you go in to donate, they're going to ask you your donor's full name. You have to have a picture ID, a permanent address, because if anything, if your results are positive, they need a way to, get in contact with you. Your date of birth, gender, then of course, date of last donation. Educational materials are provided. So if you all can recall when we did tour Vitalent, for those of you that donated, before they took you back into the assessment room, I guess you would call it, you were handed some materials to read to let you know all the testing was going to be done, some of the symptoms that may occur while donating or after donation. Then there's a health history interview. So once they take you to the back, I think they do the physical part first, where they check your vital signs, but also you have to answer a donor history questionnaire. So that's on page 304. So it starts out with, general health questions. How are you feeling? Are you taking antibiotics? Now, they have taken your temperature, but they also ask, have you taken any antibiotics? Because if you're taking antibiotics, then you must feel that, you're probably not feeling well, or you're taking antibiotics. What bacteria are you trying to get rid of? So you probably would not be a good candidate. So all this is now, of course, computerized. So the donor sits in a room and answers all these questions. They're probably about, your book has 48. They may be, a few more. I'm not sure if these are the exact questions that matches with, what Vitalent has, but it's pretty close. So it'll ask you about different medications. Of course, aspirin is a question because when you donate blood, it's considered whole blood because it has all the components in it, your red blood cells, platelets, and plasma. So if you've taken that aspirin, we know what aspirin affects our platelet count for, 7 days? You should have learned that in heme 2 with your coagulation. But so yeah, now even though you've taken aspirin, you would not be deferred as a donor. The only difference is they will not make platelets from your unit. They would just do the red cells and the plasma. So yeah, there's a different set of questions that categorizes patients, if you have to be deferred. And, they also ask you about your sexual history because some sexual content is considered high risk. So you have to, again, you're supposed to be answering these questions, honestly, because, for each of these questions, whether you answer yes or no, the questionnaire will let you complete all the questions, and then at the end of the questions, they'll ask you to elaborate on, the questions that you answered yes to. So the donor's eligibility is the determination that the donor is qualified to donate blood and blood components. Then the suitability of the donation means whether that donation is acceptable for transfusion or further manufacturing. So, if you pass the questionnaire and the physical part, then you're eligible. But just because you're eligible doesn't mean that your unit will be acceptable for transfusion. That goes on with the, if any of those tests are positive, RPR, HIV, things like that. So Vitalant and LifeShare, these are the two blood centers that I know that exist in Louisiana. These facilities utilize blood products for transfusion. People donate blood as a service because there is no substitute for blood. But donors are not paid for their donations. But you have other facilities. You may have heard the name Telecris Plasma, or I think Telecris has been changed to Grifols. So where people go and donate plasma and they get paid for their donations. So these plasma products that they use is mainly what we use for our quality control materials, like say, for instance, in chemistry. This is why, we wear gloves, and on the vials they say may contain human or human specimens or something to that nature. So you have different types of deferrals when you're donating blood. Donors may be deferred indefinitely, permanently, or temporarily. So indefinite deferral is due to current regulations that may change in the future. A donor states that he lived in England for 1 year between 1980 and 1996. So let's say, something that may change is that, that's no longer needed, or the years have, either the length of time may change or the time frame of the year may change, 1980 to 1986. A permanent deferral is required based on high-risk behavior or a positive test result. So donors with permanent deferrals are not expected to ever regain donor eligibility, even if rules or technologies change. An example of this would be positive tests for hepatitis B surface antigen. Temporary deferral is recommended if the donor will be eligible at a specific time in the future. Mainly, an example of this would be body piercings or tattoos. And those are deferred for 12 months. So, after a year, you would then be eligible. And so a lot of these questions become important because sometimes you forget that you had a tattoo, 6 months ago. So it's not until you So like even if you donated, then once you donated, you remember that, oh, I got this tattoo 6 months ago. You would call in to let them know that you did have a tattoo, and they probably would disgorge your unit. You see here on this slide, family history of CJD. That stands for Creutzfeldt-Jakob disease, and then the VCJD is a variant of the Creutzfeldt-Jakob disease. This causes a degenerative brain disorder. In the 1990s, the United Kingdom developed a disease from eating diseased cows, mad cow disease. The first for potential transfusion transmitted infections. So, history of malaria deferred for 3 years, depending on if you lived in any endemic area. Babesiosis, Chagas disease, Leishmania, and Creutzfeldt-Jakob disease. Commented in the note section about cytomegalovirus or CMV. So CMV is transmitted in white blood cells. CMV is a risk to premature infants, bone marrow recipients, or immunocompromised recipients. So blood for these patients must be CMV negative. Now the book says, premature infants, but I think all infant or baby transfusions are CMV negative. So you'll see the unit of blood, and also that unit will be tagged CMV negative to alert. So this is a test that's not often done, but normally, so units for babies are collected in what we call, it has the large donor bag, then they may have 4 little bags attached to it called satellite bags. And so they'll save some units off of sides for, infants. Let's say a hospital like Women's and Children or Lafayette General any hospital that has a NICU where, babies do get transfused often. They would have an inventory with CMV negative blood on hand already tested. Graft versus host disease, prevented with irradiation of cellular components, viable T lymphocyte and donor blood attack recipient, and that's usually fatal. So just like a bone, any type of liver transplant, bone marrow transplant, that patient's body rejects the transplant, a person can have a rejection to the blood as well. Temporary deferrals, not any types of vaccines. These vaccines that are listed. So yeah, if you get the flu vaccine, that's not a cause for deferral. If you just had a baby, you would have to wait 6 weeks. Then, of course, tattoos fall under 12 months. If you accidental needle sticks, that also cause you for a cause for deferment. Because with the needle stick, let's say, of course, it will happen on the job. So if you get a needle stick at work, an incident report is initiated and blood is drawn on you. And if you stuck yourself with a known patient, blood is drawn on that patient. But sometimes, that's why you got to be careful of placing items in the sharp containers and things like that. You never want to put any sharp objects sticking up because someone can accidentally stick themselves with it, and then they wouldn't know who is who was that person stuck, with that particular needle. So usually you'll have blood drawn every maybe like 3 months. making sure everything is negative. So most medicines are accepted. So if you know you're going in to donate that day, blood pressure medicine is okay. But you don't want to not take your medicine and then feel ill. Then there's medicines that are cause for deferral. One that's on this list is, my son was on the medicine Accutane. That's for severe acne. So you see, you have to be deferred from 1 month. Accutane is pretty strong. Because even with that, my son had to have blood drawn. I think it affects your liver, so he had to have his liver enzymes monitored while taking this. And of course, it's y'all talking about coumadin and heme 2 that prevents blood clots. But if they're going to draw you, you don't want your blood to be too thin. So again, that's just like aspirin. It's going to take 7 days to get your blood and platelet count back to where it should be. Okay, the physical exam. So the donor text takes you back in the little assessment room. So they're going to take your blood pressure, temperature, check your pulse, make sure you weigh 110 pounds. Age. If you're a minor, you have to have parental consent. And they changed, because I don't know how long ago it has been changed, but they started targeting the younger population because, not enough people were donating blood. So now they frequently hold blood drives at the high schools, to keep a good source of inventory. So donors weighing a minimum of 10 pounds can tolerate a maximum withdrawal of 525 milliliters. So donors weighing less are not restricted. So in all honesty, if you weigh less than 110 pounds, you should not be rejected, but less blood should be removed. And then the maximum withdrawal for someone less than 110 pounds would be 473 ml. Now these bags, contain anticoagulant. So think of it, say like the blue top. There's a certain ratio of blood to the anticoagulant that you have to have. So that's why less blood is drawn, and then some of the anticoagulant has to be removed as well. So I guess a lot of donors do not. That would be, I guess, a lot of work, and of course, preparation and things like that. Now, your blood for the hemoglobin is collected with a finger stick, and it's then tested with a point of care device, meaning that they check it right there. So they'll prick your finger. I can't remember if they draw up the blood in a capillary tube or it's on a little strip like a glucometer. But so once they have the drop of blood, they'll get the results within 30 seconds. So at that point, they can determine whether or not your hematocrit level is high enough to donate. Because, of course, if you're anemic, they're not going to take blood from you and then, have you feeling bad or you need your blood back. Like I know I'm usually borderline anemic. So if I have a date scheduled, I try to eat um, foods higher in iron to increase my, iron content, or and eat, red meat a couple of days before I go to donate, so I can hopefully have my crit, above 38 percent. And then with that donation, time between donation is 8 weeks. Some of you've run out of time for the extra point. I only had one person that brought me a donation sheet. So after you finish your assessment, everything checked out well on your questionnaire, you passed the physical part of the examination, and they'll walk you to the donor room where they place you in uh, the reclining chair. So the donor, again, because sometimes it's the same donor tech that does your questionnaire and will collect the sample from you. Sometimes it is a second donor tech. So they're always going to confirm your identity, because at that point, like they'll pull the bags come pre-packaged in a sterile package, and so the donor tech has your information, and then once they open that pack, those stickers, that W0365, that long number, they then put that number on your, information sheet to keep track of everything. So the donor tech confirms identity. All bags and tubes must be labeled. So the best site to draw from is the antecubital area, because that's our largest vein, right? Oh, I don't know what happened. So yeah, that's our largest vein, because it's important, because the size gauge needle they use is 16 gauge. Now, if you've never seen the gauge, or to look at that needle, it's pretty big. So it's probably about the size of most people's veins. So now what we draw in regular phlebotomy is a 21 gauge needle. And remember, as the numbers decrease, the size of the needle increases. It's opposite of what you think. So normally blood is drawn in a regular venipuncture with 21 gauge or 23 gauge, but blood donations are collected with a 16 gauge needle. Like I said, it's bigger, so the blood can flow a lot better. And remember, you're trying to give out 500 cc's of blood, so that's going to, you need to have that, a good blood flow for that. So from the time that the donation starts, it should take about 8 to 12 minutes. They normally have you do, they'll give you a stress ball to hold so that you can open and close your hands, so, to pump up the blood and help that speed it up. Open and close, 3 to 5 seconds. They also have you tighten your calf muscles and buttocks and then release. I think that helps you from fainting. So yeah, you're in a reclining position, so to help, because your feet are elevated a little bit, and in the event that a person does start having symptoms or dizziness, that chair is able to, it's movable, so they can take you and set that chair up to where your feet are even higher and even more above your heart. So yeah, cleaning the arm, they of course tie a tourniquet around the arm, and they scrub the area at least 4 centimeters in all directions from the center outwards. What does that sound like? How do we the same way we would collect a blood culture, right? You're trying to make that area of the venipuncture sterile. So starting at the intended site of venipuncture and moving outward in a spiral, let the solution stand for 30 seconds. And then they'll cover the area with a dry, sterile gauze until they're ready for the venipuncture. But once they clean your arm, they have all the materials right there next to them, ready to go ahead and make the venipuncture. Same as in blood cultures, that skin has been prepared and should not be touched again. And, they place that sterile gauze on there because they shouldn't be talking over it and you shouldn't be talking over it. Do not repalpate the vein at the intended blood culture site. So this is what the bags look like. So you'll have one larger bag that, this is the needle. And, the bag is set up with different little clamps. Here's one and here's one. So I think this first bag, I think this is the one that the whole blood is donated in. And so then afterwards, depending on whether or not, so you'll have the whole blood, then, it goes through its process. Once they take it to the back, the processing center, you'll get your plasma, your fresh frozen, cryo, and then platelets, I think, may be in this bag. So the initial bag contains anticoagulant because that blood is going to be flowing in the tube and you have to prevent it from clotting. Maximum volume where it's going to be 450 plus or minus 45 mils. So if they intend to make components from your whole blood, they'll hold it for up to 8 hours at 20 to 24 degrees. Otherwise, they'll store it at 1 to 6 degrees, which is the regular refrigerated temp. So as the blood donation is, the blood is in process of collection, you may see a device similar to this. Now, this one is a mechanical device. So the donor tech will place the bag into that tray. So once the donation starts and the blood starts flowing, as the bag begins to fill, the bag, it's on a rocker, so it'll start rotating. And when it gets, so you can see that this meter is digital, so when it gets to the volume size, let's say 500 mils, it'll stop. So frequent mixing of the blood during donation with an anticoagulant or a preservative in the bag is critical to avoid blood clots and can be formed manually or with a mechanical device. So if a mechanical device isn't available, the donor tech would have to mix it, by hand. Of course, if they're using it at the blood center, they can probably just switch a mechanical device out if one happens to break or go bad. But, oftentimes they'll come to different, sites or a blood drive. So all they would have to do is invert it. Just like we would do our tubes, this is what they would do, constantly mix the bag to making sure no clots are formed. Because if you have a clot form in the bag, that would have to be discarded because there's no way you could give that to a patient. You wouldn't even be able to transfuse it because, a clot, that tubing, it would clog it up. It wouldn't be able to go through. So this is another type of scale to where they set it on there and it's, weighted to probably 475, 500 cc's. So once the donor tech makes the venipuncture and gets the flash, the blood is going to come back through the tubing where it gets clamped off to, like, from the right side on the right tubing, so that the blood can, the first 10 to 20 mils of blood can go in this little diversion pouch right here. So that's used to prevent contaminations with skin cells and any potential bacteria entering the donor unit. So if that donor tech didn't clean the surface real well, because, once you make that venipuncture, 16 gauge, that's making a pretty big hole in your arm. You can introduce a lot of bacteria through that venipuncture. So the rationale is if we divert the first 10 or 20 mils of blood, it kind of flushes out any bacteria that may have gotten into the, inside of the needle. So, and as you see, there's a little vacutainer holder attached to this as well. So once the donation is in process, they'll go ahead and draw a purple top, a pink top, and 2 or 3 red tops. The blood that they'll need for the type and screen, the RPR, hepatitis antigen, the anti-HBC, hepatitis C, HIV 1 and 2, HTLV 1 and 2, and HIV 1 antigen. So once the donation process gets going, you sit there, you're pretty chill. They ask you, if you want something to drink. So, bottled water, chips, snack. That way, you continuing to replenish your fluids and, the saltiness or the sugar, whatever your preference is. But, sometimes donors will just have an adverse reaction. They'll start to feel weak or get sweaty or feel dizzy, get cold and clammy. So, in this instance, like I said, they will try to, elevate your feet. They'll put an ice pack on your chest or your neck, trying to calm you down. But, in the event you do get sick, with the weakness and sweating, because they don't want you to fall, they're going to remove that needle because they don't want you to fall and injure yourself. A common reaction is a hematoma, because remember, that needle is so big, unless you have veins like mine, it may be difficult to, get into your vein. And most of those donor techs have been doing this for a while, but it's just like anything else. If they have a hard time drawing blood from you with a 21 gauge needle, just imagine a 16 gauge needle. And I think we have a bag in the lab. I'm gonna have to look, and we can compare the needle size or the bore or the hole of the needle, and you can see what I'm talking about. So of course, if a hematoma forms, they have to apply pressure, and then more than likely that's going to leave some type of bruising as well. But anytime, after the post-donation care, donors are advised to contact the donor center with any concerns about blood safety. So let's say, like, Miss Black and I took you to Vitalented as a school project, and you didn't want somebody to know, maybe someone has a history of hepatitis. You were, stuck by a needle, 2 years ago and contracted hepatitis, and, you don't want anybody to know. So you may not say anything through the donation process, but after you leave, you will call the blood center and say, hey, please don't use my blood. I am, positive for hepatitis or something like that. Avoid smoking and drinking alcohol after donating. They tell you to drink additional fluids. If you start to feel lightheaded once you leave, of course, lie down or sit down. Try not to do anything strenuous. Because 500 cc's may not be a lot, but this is something that you don't do every day, so you really don't know how your body's going to react. Especially, I know some of you don't eat very well. I hear y'all were talking about all I had was coffee. Sometimes that doesn't fly. Your body needs those nutrients. And then the bandage, they ask you to keep that on for a couple of hours. They wrap your arm real well, kind of tight with that Coban, and that's to prevent a hematoma. Because with that needle being so big, if you don't leave it on, you have to leave it on longer than 10 minutes. It's not like a regular venipuncture. In 10 minutes, your blood, should clot. Where your body should form a platelet plug to stop the bleeding, and you're pretty much good. But that's with the small needle. The 16 gauge is much bigger and needs more pressure for a longer period of time. And if you have any other additional symptoms, notify the blood center. And they give you that paper. They give you a paper after donation with your donor number and a 1-800 number to call in the event that something may happen. So autologous donation. So you'll have allogenic donations for the general population. That's what we all normally do. And then there's autologous donations when you would go in and donate for yourself. So this procedure is only used for stable patients or useful for patients with rare antibodies. So if you have a rare antibody and you're pretty stable, you may go and donate blood for yourself, and they have the ability to freeze blood. We're going to talk about that in chapter 15. Or you may have a patient whose religious beliefs that do not allow allogenic transfusion. So if they would happen to have a surgery requiring blood, they can go and donate for themselves. But once that autologous unit is collected, it has to be tagged autologous use only. So there are special tags at the blood center, and you may come across this on the blood bank shelves in the hospital laboratories. When a unit is autologous, you'll know it'll have a sticker on it. So how is this determined? So if you're going to a surgery that may require 2 units, and usually there's that maximum scheduled blood order surgical list that we talked about or kind of mentioned in one of the last chapters. So for each type of surgery, there's a limit. So some surgeries only require, type and screen. Some surgeries require that you do type and screen with 2 units. So if you had a surgery, let's say, appendicitis. I don't think appendicitis needs a cross match, but let's just say you're going in to have your appendix removed or your gallbladder. So the doctor, would give you your surgery date, but you would tell the doctor, hey, I'm not sure I want to, take blood from anyone else. Because, still a lot of people are worried about contacting, HIV or hepatitis from the donor unit. And, this has happened because it might be 30 years ago. This is when, HIV first came into play. So you had hepatitis. before there was hepatitis and HIV testing, people were getting that through blood donations because they were being tested for it then. So a lot of people are living with those two types of illnesses because of blood donations. So you can, understand their concern. And true enough, even though there's testing, we learned that also that there's a window where, the conversion hasn't been made if something is truly positive. So you would request that you donate for yourself. The patient autologous donor crit has to be no lower than H&H can be no lower than 11 and 33. Blood collection should be completed more than 72 hours before surgery, and there's no age restriction. So the donor unit, the autologous unit is collected. The A, B, O, and D type is determined at Vitalant. Autologous units cannot or not used. If an autologous unit is not used, it cannot be used in general inventory because they have not met the same donation requirements as allogenic. So it doesn't go through all the testing because all you're doing is basically taking some blood off of you and say, hey, I'm putting it in reserve, and if I need it, just give it back to me. So it's your blood. It doesn't have to have all that special testing. But this is why it's going to be discarded after that unit. As long as you stay in that hospital, your autologous unit stay in the hospital. Once you discharge, they'll call the blood center, and I think that they'll come pick it up and they'll discard it at the blood center. Now, with the procedure on an autologous unit to cross-match that, because the doctor is still going to order cross-match ×2 unit, and they may put in comments, patient has autologous unit. So again, the autologous is retyped just like any other unit would be, but some facilities also perform a cross-match. If the person's antibody screen is negative, then they only would have to do an immediate spin. If that person has a antibody, then they'll probably would have to do it through gel. So whatever your hospital policy is. So types of autologous units, you have preoperative, the first one. Blood is drawn and stored before an anticipated date, meeting the criteria of 11 and 33. The second one, normal volemic, removing units at the beginning of surgery and refusing them at the end of surgery. This is done through a special machine. I don't know what the difference between normal volemic and the blood recovery. I've maybe known of one surgery where they did do like the blood recovery to where an instrument is brought to surgery. It's almost like a salvage device. So it is used to wash, filter, and concentrate blood during an operation. So in the event that instead of using a donor unit, and I don't know what the H&H criteria for this type of donation would be. I assume it would be the same. They would take your blood, make it go through this process, and then give it back to you. So if you are in going to the hospital or having a surgery, and let's say you did not meet the criteria, you're scared about getting blood from the general population, and you didn't meet the criteria of 11 and 33, you're 8 and 24, but you said, hey, can I have my, spouse or significant other or my brother donate on my behalf. So these donors are called directed donors. Uh, they would go into Vitalant and say, I would like to donate blood for, they would give the patient's name. And I think so if the patient expressed concerns, the doctor probably would have to write up a form, and then that form is given to that directed donor, and that's what he would take to Vitalant. And that way they'll know who the directed donor should go to and at what facility. So no evidence supports the theory that directed donations are safer than allogenic donations. This is what I've always said. Unless it's your spouse or significant other, how can you trust anybody else? Rather, just because they're related to you, that doesn't mean that their blood is any safer than anybody else's. They have to answer the same donor questions too. So they go through the same process as a allogenic donor. So this is saying the 56-day interval may be waived with a medical doctor's approval. So I guess if someone was donating on behalf of someone else, you would not have to wait the 8 times 7. Yeah, 8. So yeah, that's still the 8-week interval. Then of course your hematocrit would have to be high enough to do that. Apheresis. This is where components are separated and the blood is returned back to the donor. So leukapheresis, white blood cells are removed, the red blood cells are given back. Plateletpheresis says donations are made at least 48 hours apart. So you can do this it says no more than twice a week, and your platelet count has to be 150,000. My mom had leukemia, so her platelet count was low. So on her behalf, me and my brothers, we went into the donor center and donated platelet pheresis. So what happens with the pheresis, you're stuck twice, tubing to take the blood out and one to take, put it back in. So with the platelet pheresis, you get like a concentrated bag of platelets, so to speak. Whereas when you're taking platelets off a donor unit, you'll get single bag platelets. And we'll talk about that too in chapter 15. So plasmapheresis is not commonly done. Then there's the red cell apheresis. So 2 units of red blood cells may be donated if the weight and height requirements and the crit are met. So what this means, if your crit is high enough, they'll ask if you want to donate a double red. So the double red, they'll put that patient drawing with blood on a different type of machine to split the unit. So in your blood bank inventory, you may come across a unit, 2 units with the same donor number, and this is why. They're now making, double reds. So when we do have that in our facility, if we see, 2 units and a person needs 2 units, we just try to give, those 2 units to one particular patient. Does it matter? No. But it helps, with record keeping and things like that. So you're able to give, you'll help 2 people receive red blood cells. I'm not sure how the components work on that. I'm going to have to ask next time I go there. But you can see the deferral is 16 weeks because they're taking a little bit more of your red blood cells. So donation interval has been extended. And this is what the apheresis unit looks like. I'm not sure I'm sure everything is done internal as far as the separating part. I think they may have some type of centrifuge in there because so that they can withdraw the platelets and then return the red blood cells, back to you. The therapeutic phlebotomy. So therapeutic phlebotomy is performed to withdraw blood from a patient for medical reasons. So it's usually done on patients that have been diagnosed with polycythemia vera, hemochromatosis, or the porphyrias. So these people usually have a high hematocrit. One of the symptoms is the reddened face or the rosy cheeks, like Santa Claus cheeks, indicating that they have a high or elevated iron content. So removal of the blood does not cure the disease, but it treats the patient's symptoms. Because a lot of times they'll have, shortness of breath or something like that. So every so often, let's say someone with polycythemia vera, they have to have their H&H done, let's say every 3 months. So every 3 months, the doctor checks their H&H. Their crit is high. I don't know what the guideline is. I think it may be over 55. So if the patient's hematocrit is over 55, the doctor is going to order a therapeutic phlebotomy. So I know when we had it at Jennings, we only did it on our inpatient. So if our outpatient needed a therapeutic phlebotomy, we would send them to, life share. Service to the donor for phlebotomy must be free of charge. I didn't know that. So that was interesting. I don't know if that's fact for all blood centers. So the procedure, so blood needs to be withdrawn. Now they don't have to go to the blood center. And again, therapeutic phlebotomy, that blood that is drawn or collected on that patient is discarded. Because too high of a crit is not a good thing either. So that unit is discarded. So for a therapeutic phlebotomy, vital signs are taken before and after. A pre-hematic H&H is done and a post-H&H is done. Because that way we can see if the hematocrit is dropped. It's the reverse of what we've been learning all before. We transfuse blood when the H&H is low, but with a therapeutic, you're trying to get rid of it, so you're trying to decrease the hemoglobin and hematocrit. So at Jennings, we would only do it on our inpatients, but we did have an employee that I'm not sure which diagnosis he had, but I think when he was first diagnosed, we didn't have any bags, because we don't collect donors, so we didn't have any bags to remove the blood. So what we did at that point was collect probably like 10 red top tubes, just kept drawing blood from them so it was a big plain red top, kind with no gel, so they may have held 10 or more cc's, so 10 of those times 20 about 200 cc's, and then we would check the H&H again to see if that did them any good. Okay, that's on therapeutic. That's all for blood. collection and donation. Share another study tool. Also, at the end of chapter 13, if you wanted to get some practice on trying to learn, the vital signs and things like that, the study questions are real helpful for that. Sure that. I copied this out of the LSU book. This is sort of, a recap of what chapter 13 is about, but it gives you, pictures. So here's Danny Donor. We know that the patient has to be 110 or more. The hematocrit, the blood pressure, the temperature. When you're determining the blood pressure, you have a systolic and diastolic. Systolic is your top number. You can remember by sys, the S in systolic and the S in sky. Diastolic is your bottom number, or D for dirt. Because, a BOC question would give you a bunch of, a set of vital signs and ask you to determine, is this donor acceptable for donation? So just going through those questions and, working a few just to get your mind on that track. You don't have to do this now, for my course, but when you get in clinicals and you're in your blood bank rotation, this is something you definitely want to go over. And here again, this is the donor deferral list. It has everything put together with the different disease states. Now, the collection of the blood. If a donor of low weight does give a unit of blood, or sometimes, let's say, you are the correct weight, or most of the time, if a patient, let's say, fainted or experiencing nausea or dizziness, and they have to stop the unit. So if they get to at least, 300 cc's, they're still able to use it. So they'll tag it low volume unit and put whatever the volume that's on there. It's not discarded if they can at least get, 300 cc's. If you start feeling bad midway between your donation. But here also is a calculation that can be done to remove the amount of anticoagulant based on, I don't know if they would have separate bags. Okay. See, I guess that's why they say reject you folks that weigh less than 110 pounds. See, they would have to do math, and they're not doing it. The bags, we're going to talk about that in Chapter 15 as well, the different additives and things like that. Let's see. Give some more information on autologous units, and it compares autologous donation criteria with the heterologous or the allogenic as the term that was used in our textbook. Oh, it goes through the different apheresis collections. So yeah, chapter 14 will be about the test performed on the donor blood. So you're mainly focusing on we know ABO or ABO and RH, and then each donor unit is screened for clinical significant antibodies. So right here it says FFP, or the fresh frozen plasma, cannot be prepared from these units because, that'll be in their they have those antibodies. Let's see, but you can get platelets in cryo. So yeah, I'll talk more about this in chapter 14, but I know y'all went through most of these tests in Ms. Black's class, so that's why I'm not really going to elaborate on them. Just pick out some highlights about each test. And again, that information will not be on the test either, chapter 13 or 14. You can wait till you get into your blood bank rotations to study more about those. Okay, hopefully this recording takes. And that's it. I'll see y'all on Tuesday.